Welcome to KJR SummaryCast. SummaryCast provides audio summaries of KJR articles created using an in-house AI tool with editorial or author review. For full details, please refer to the original article.
Welcome to SummaryCast.
What's the paper for today?
We're looking at a review article from the July 2026 issue of the Korean Journal of Radiology.
And the topic?
It's titled Updates on Imaging Assessment of Pancreatic Cancer for Determining Anatomic and Biologic Resectability.
Pancreatic cancer. That's a heavy topic. The 5-year survival rate is still stubbornly low.
It is. And as the paper lays out, complete surgical resection is still the only shot at a cure.
But there's a major hurdle.
Right, and it's the one this review really unpacks. How do we decide who is and who isn't a candidate for that surgery?
The paper argues that the old way of thinking, just looking at the anatomy on a CT scan, is falling short.
Precisely. The field is moving toward a much more integrated approach. But to understand where we're going, we have to start with the foundation.
Which is the classic anatomical assessment.
And that means starting with the pancreatic protocol CT.
The workhorse. This isn't just any old abdomen-pelvis CT, right?
Not at all. It's a specific protocol optimized to see the pancreas and the structures around it.
What's the key difference?
It's all about the timing of the intravenous contrast and capturing two specific phases.
Okay, what's the first one?
The pancreatic parenchymal phase, around 40 to 50 seconds after injection.
And why that specific timing?
Because that's when the normal pancreatic tissue enhances most brightly. Pancreatic ductal adenocarcinoma, or PDAC, is typically hypovascular, so it shows up as a dark, poorly enhancing mass against that bright background.
Maximizes the contrast to see the tumor. Got it. What's the second phase?
The portal venous phase, a bit later, around 65 to 70 seconds.
And this one is for...
This is when the portal vein and superior mesenteric vein are fully lit up with contrast, which is perfect for evaluating any tumor involvement of those veins. It's also the best phase for spotting liver metastases.
So you get one look optimized for the tumor itself and another optimized for the veins and liver, and the main goal is mapping the tumor's relationship to the major blood vessels.
Exactly. That relationship has traditionally been the absolute determinant of resectability. The paper lays out the standard classification,
Which is all based on the degree of contact.
Right. First, there's no contact, the best case scenario. A clear fat plane separates the tumor from the vessel.
Then
Then there's abutment, where the tumor touches the vessel, involving 180 degrees or less of its circumference.
And abutment can be with or without vessel deformity, like if the tumor is pushing on the vein and indenting it.
That's right, and that distinction is critical. Finally, there's encasement, which is contact of more than 180 degrees.
Essentially, the tumor is wrapping around the vessel, and these imaging findings map directly onto the clinical staging for resectability.
You nailed it. The NCCN guidelines use this information to sort patients into 3 buckets. Resectable is when there's no contact with major arteries and at most venous abutment without any deformity.
Okay, that's the first bucket.
Borderline resectable is the gray zone. This could be venous involvement that looks reconstructible or abutment of an artery like the superior mesenteric artery or common hepatic artery.
And locally advanced is the clearly unresectable category.
Right. That's for tumors with arterial encasement or extensive, unreconstructible vein involvement. Basically, the tumor is so entangled with critical vessels that a surgeon can't get it out without causing catastrophic damage.
It sounds very geometric and clear-cut, but the paper immediately points out some pitfalls.
It does. Things that can make this assessment really tricky. One of the most important it highlights is perineural spread.
Define that.
This is a really subtle but critical concept. The cancer cells can spread along the nerve sheaths that travel with the blood vessels,
Creating a sort of soft tissue infiltration that extends far beyond the main tumor mass.
Exactly. So a radiologist might see a small, seemingly innocuous 1.5 centimeter tumor in the head of the pancreas, but not appreciate this subtle, sheet-like tissue tracking along the arteries.
The paper has an example of that in Figure 3, right? Small primary tumor, but extensive infiltration.
That's the one. It's a disconnect that can lead to a major underestimation of the tumor's true extent.
That's a huge red flag. Another pitfall mentioned is arterial variance.
A classic one.
especially a replaced or accessory right hepatic artery coming off the SMA.
Why is that one so important?
Because that artery runs right through the portocable space, posterior to the pancreatic head, prime territory for invasion from a pancreatic head tumor.
So if you don't spot that variant anatomy, you might miss tumor involvement of a critical artery.
You might. It underscores the need for meticulous evaluation. But even when the anatomy is perfectly assessed, there's a bigger problem.
Which is the core argument of this review, the limits of anatomy itself. Even patients who get a technically perfect, quote, margin-negative resection can have a high recurrence rate.
Exactly. And that's the paradox that forced the field to evolve. It led to this concept of biological resectability.
In practice, what does that mean?
It means that the anatomical appearance is only part of the story. Some tumors, even if they look anatomically contained, are just biologically aggressive.
They've likely already sent out microscopic seeds of disease.
Precisely. Surgery might remove the primary tumor, but the recurrence is almost inevitable. So we need a way to identify these aggressive tumors before rushing to surgery.
We need biomarkers of that aggressive biology.
And the review highlights a few key ones, starting with the most widely used, the serum marker CA19-9.
Right, the carbohydrate antigen 19-9. How is it used to stratify risk?
A very high preoperative level is a major warning sign. The paper cites a common threshold of 500 units per milliliter.
And there's a study mentioned by Ushida and colleagues that was pretty compelling on this point.
It was. They showed that patients with anatomically resectable PDAC, but a CA19-9 level over 500, had a survival curve that was much worse than those with low CA19-9.
So their survival was actually comparable to patients who had borderline resectable disease.
That's right. The biology, as measured by that blood test, was a more powerful predictor of outcome than the anatomy on the CT scan.
So a high CA19-9 is a biological red flag that suggests the patient might benefit more from upfront chemotherapy.
Exactly. Though, to be fair, the paper does note some caveats with CA19-9.
It's not perfect. Biliary obstruction can cause it to be falsely elevated.
Correct. So you really need to measure it after a biliary stent has been placed and the bilirubin level has come down.
And some people just don't make it genetically.
That's right, the Lewis antigen-negative population. In them, the marker is useless, but for the majority, it's a powerful prognostic tool.
Okay, so beyond blood tests, what about clues on the imaging itself? Do certain imaging phenotypes suggest more aggressive disease?
Yes, the review points to studies showing that tumors with central necrosis on CT or those with a distinct rim of enhancement on MRI tend to be associated with a worse prognosis.
So those imaging clues are really pointing toward aggressive pathology, things like poor differentiation and a higher likelihood of lymph node metastases.
You got it. And PET-CT also seems to have a role here.
It's not used routinely for initial staging, but it could be helpful.
It could. While it's mainly a problem-solving tool for finding occult distant metastases, some studies suggest the metabolic activity of the primary tumor, measured by its SUV max, has prognostic value.
So a very hot tumor with a high SUV max may signal more aggressive biology.
That's the idea. So you have these different streams of information, anatomic from CT, serologic from CA19-9, and metabolic from PET, that together build a more complete picture of risk.
It's a move away from a single-factor decision, and this more holistic view is what's driving the big strategic shift in treatment.
The rise of neoadjuvant therapy, or NAT.
Giving chemotherapy before surgery.
Right. For borderline and locally advanced disease, it's become the standard of care. The goal is to shrink the tumor and potentially convert an unresectable case into a resectable one.
A conversion surgery.
Exactly. But the more recent and debated application is using NAT for these high-risk but technically resectable patients.
The ones with a very large tumor or that sky-high CA19-9.
Correct. The idea is to treat the microscopic disease that's probably already out there, and also to test the tumor's biology.
If the cancer progresses despite chemo, then surgery probably wouldn't have helped anyway.
It's a biological stress test. But, and this is a huge but that the review spends a lot of time on, this whole approach creates a massive new challenge for imaging.
The challenge of restaging.
Yes. After several cycles of chemotherapy, you get a new scan. And the critical question is, has the treatment worked well enough that the patient is now a candidate for surgery?
And the problem is that fibrosis looks a lot like tumor.
That's the crux of it. Chemotherapy and radiation kill cancer cells, but they leave behind scar tissue. On a CT or MRI scan, that scar tissue can look almost identical to residual viable tumor.
So the scan after treatment might show what looks like persistent encasement of an artery.
When in fact, it could be 90% dead scar tissue that a surgeon could easily dissect away.
That's a non-trivial problem. It means imaging systematically overestimates the extent of viable tumor after treatment.
It does. Multiple studies have shown this. The radiological response often doesn't correlate well with the pathological response.
There was a striking example of this in the paper.
The study by Ferroni and colleagues, they reported that 92% of patients achieved an R0 resection after NAT.
Which is a great outcome.
But radiological downstaging to resectable only occurred in 35% of them.
Wow, that's a huge gap. It means if you relied strictly on the post-treatment scan's anatomical appearance, you'd deny surgery to a lot of patients who could actually benefit.
An enormous gap. So this is where the review really pushes for a more sophisticated approach to restaging. It argues you can't just apply the same old anatomical rules.
So what's the better way? How do you get around the fibrosis versus tumor problem?
You have to look for signs of response across multiple domains, not just the tumor's size or vessel contact.
Okay, such as?
First, look at the change. Has the degree of tumor vessel contact regressed? Even if some contact remains, a clear reduction is a very positive sign.
So it's not a binary contact versus no contact anymore, but a more dynamic, is the contact getting better?
Exactly. Second, and maybe even more importantly, you have to integrate the biological markers.
Like, what did the CA19-9 do?
Precisely. If it started at 1,000 and is now down to 30, that's a powerful signal. Normalization, or a drop of more than 50%, is consistently associated with better surgical outcomes.
What about PET scans for restaging? If you have a baseline, you can see if the tumor is still metabolically active.
This is another key element. The paper highlights a study by Yu et al. That's particularly neat.
What did they find?
They found that if an area of residual tumor vessel contact on CT showed no FDG uptake, meaning it was metabolically cold on the PET scan, it was much more likely to be fibrosis.
Whereas if that area of contact was still hot on PET, it was more likely to be persistent, viable tumor.
You got it. The PET provides functional information that helps you interpret the ambiguous anatomical findings. Figure 10 in the paper is a perfect illustration of this.
Walk me through it.
It's a case of borderline resectable cancer. Initial CT shows tumor abutment of the SMV and SMA. Initial PET is blazing hot.
Okay.
After chemo, the follow-up CT shows the tumor has shrunk, but there's still some residual soft tissue abutting the SMA. Anatomically, it's equivocal.
But
the follow-up PET scan is completely cold, a complete metabolic response, and the CA19-9 normalized.
And the outcome?
The patient went to surgery, got a margin-negative resection, and was recurrence-free 8 years later.
That's a home run. A case that might have been denied surgery if you only looked at the post-treatment CT anatomy.
In isolation, yes. It's the synthesis of all three: anatomic regression, serologic response, and metabolic response that provides the confidence to proceed.
So let's land this. The big picture here is a paradigm shift in how we think about resectability for pancreatic cancer.
It absolutely is. We're moving away from a static, purely anatomical framework and toward a dynamic, multi-domain risk assessment.
The question is evolving from a simple, can we cut this out, to should we cut this out, and if so, when?
That's the bottom line. It's about personalizing the strategy. A patient with a small tumor and low CA199 might go straight to surgery.
But a patient with a similar-looking tumor on CT, but a very high CA19-9, is a different biological entity, and they likely need neoadjuvant therapy first.
Right. So, for the practicing radiologist, what are the key takeaways from this review?
I see two.
Go on.
First, at initial staging, the paper suggests the radiological assessment shouldn't stop at just describing vessel contact. It highlights the importance of looking for those subtle, high-risk features, like perineural spread.
And to be aware that the clinical context, especially the CA19-9 level, dramatically influences prognosis.
Right. The paper seems to argue that the radiologist's findings help place the patient on a spectrum of biological risk, not just anatomical stage.
Well put. And the second takeaway?
It's for restaging after neoadjuvant therapy. The paper makes a strong case for interpreting scans with an understanding of the limitations of CT and MRI and acknowledging that residual soft tissue contact is ambiguous.
And ideally, that interpretation should be a synthesis, integrating all the available pieces of data.
Right. The paper is pointing toward a report that might note, residual soft tissue contact with the SMA is seen, but this is in the context of a complete metabolic response on PET and normalization of serum CA19-9.
A report like that would provide the multidisciplinary tumor board with the full context needed to make the best decision for the patient.
A necessary evolution, as the paper calls it, for a notoriously difficult cancer.
A clever and comprehensive update on where the field stands and where it's clearly headed.
And that's all the time we have for this episode of SummaryCast.
Join us next time